It is now my pleasure and frankly humble role to introduce Senator Frist. He has more honors than frankly we have time, and he really personifies, you know that question we ask our children and we remember when we were kids, what do you want to be when you grow up? Well, Senator Frist apparently could not decide. We're heart and lung transplant surgeon, United States Senator Majority Leader, a business leader. I found that he served on a board of the company that bought the company I first started my career in. He has started Hope Through Healing Hands, which focuses on maternal and child health and global poverty. SCORE, a statewide collaborative on education reform. He has devoted his life, his passion, his intellect to the people of Tennessee and indeed the people of this nation. It is with great pleasure that I introduce Senator Frist to share a few remarks.
Joe, thank you, and it's great to be with all of you. How many here today are, wait a minute, everybody stand up quickly and sit back down. Everybody up, up, up. All right, now down. How many people are from Nashville, just so I know? So, a few. And then how many are from outside Tennessee? Okay, good. Wait a second here now. Welcome to Nashville, Tennessee. I was born here, I want to say 6 decades, a little bit more than 6 decades ago. And Middle Tennessee is one of the hottest areas in the country. And the reasons, well, a few of them say, the reasons are many, many-fold, but number one, Jack Daniels. Jack Daniels whiskey, being majority leader, I did travel all over the world for many, many years. But Jack Daniels, when people say you're from Tennessee, you know, I thought it would be lots of different things. But the number one reason people sort of applaud is Jack Daniels. It is, and it's distilled just south of Nashville here, it is the most popular whiskey in the entire world. And in this true entrepreneurial spirit, we'll be talking a lot about innovation in the next 2 days. Jack Daniels, Jack, started distilling his whiskey when he was 13 years old in Lynchburg, Tennessee. However, as many of you know, you cannot buy it in the county in which it has its origin. It is a dry county. Number two, things that even a lot of Tennesseans don't know is that here in Tennessee we have the most powerful supercomputer in the entire world. Not the South, not the United States of America, but the entire world. That machine is called Summit. It's the world's fastest computer, and I won't go into the details of that, but it's about a rate of 200 quadrillion mathematical calculations per second. Things like Tennessee produced 3 of our nation's presidents. Interesting, we're called Athens of the South. For those of you who haven't been here, you'll go further out Broadway to West End and you'll see the Parthenon there. It was named not so much about the Parthenon, an exact replica that's actually so good that when they redid the Parthenon or restored the Parthenon about 20 years ago in Athens, they came to Nashville to actually cast the original Parthenon, which is actually very interesting. But it's really not named for the Parthenon itself, but it's because that there are 21 postgraduate institutions within 5 miles of where we sit right here. And so education. Music City, USA, all of you know Music City, the moniker itself, and now it's moved into alternative music, way beyond country music. But the Grand Ole Opry is the longest running radio broadcast in America that is broadcasting today. Starting about 1925, again about 3 blocks from here, the AM radio station WSM, which is part of We Serve Millions, part of an insurance entity, but a fascinating place to go to. Silicon Valley of health services, we're moving a little bit closer into health and healthcare, and in a few minutes we'll talk a little bit about social determinants and what that means and the connectivity around that. But it's called Silicon Valley of Health Services because there's 17 publicly held companies, again within 5 miles of where we sit right now, companies that serve all 50 states, countries around the world, about 250 other healthcare entities, again within 5 or 6 miles of where we're sitting now, in health service, the actual delivery of healthcare, not so much biologicals or pharmaceuticals or devices, but actual delivery of health services. Diversity, a lot of people may not know that Nashville, Middle Tennessee has the largest Kurdish population in the United States of America. I say all that really as introduction. I loved what we've heard today so far, and this is a little bit of the transition as we go forward in terms of talking about this sort of intricate mixture of social determinants, what they actually mean. And we'll talk in just a few minutes about the language of it, and Joe and I'll get together and start and just have a conversation. Before doing that, let me just talk about sort of one thing, because it's the juxtaposition, this really interesting irony that we're the Silicon Valley of health services for this country. We have more reach, more chains of hospitals, post-acute space, ambulatory surgical care units that all originate here. So much bigger than Mass General, much bigger than Boston or LA or New York that originate out of here. But the cruel irony of it is that our health of our population, you got health care, that's doctors, Bill Frist, heart transplant surgeon, Vanderbilt, delivering care. And when we talk about health, a lot of people think about that, kind of where I started, health services itself. But health care is not health. The well-being, your overall health, the spiritual health, the mental health, the physical health, all intertwined into one. And what we're going to be talking about over the next 2 days is the real drivers of health and well-being is not health care. That health care, and it kind of hurts my feelings because I'm a transplant surgeon. I love to operate. I love to fix things. In truth, I could do that all day long and not affect the health of a community like Middle Tennessee. I'll use Nashville as an example. We're one of the hottest cities in America today. People are coming here. It's cool. You'll have fun. You'll have hot chicken. You'll see music. Tonight's a free night, I think, isn't it, Joe? I think tonight, so you'll see all that. But the cruel irony is that our public health is terrible. It is worse than countries you'd say couldn't be possible. Cuba. People die here earlier than they do in countries like Serbia or Cuba. Or even worse than that, our sister cities of Charlotte, of Austin, of Dallas, of Fort Worth, people will live longer than they do in the coolest, hottest, most energetic, good income city of Nashville, Tennessee. Live longer, infant mortality higher. You don't see it, you don't feel it, and then we have to step back and we ask ourselves, why is that? What drives that? This juxtaposition. We're a wealthy city, we're a capital city. I just told you we have 21 institutions of higher education right here, but our health is down here. Our health services, the doctors, the Vanderbilts, the TriStars, the cardiac surgeons are up here. And it's because of the social determinants of health. It's the housing. It's the transportation that we saw in the video. It's the access to internet. It's walkability issues. It's the food we eat. It's how we behave. We eat too much. The obesity rates, the diabetic rates, all of this is what is driving, and that's what we'll talk about, this connectivity. And one example that I'd like to turn to is that being majority leader was an unbelievable opportunity to serve you and you wherever you live. In my 20 years of being able to deliver care not too far from here at Vanderbilt and see the miracles of being able to take a heart out of one person and then put it in another day after day after day after day. But all of that does not move the needle in terms of where we need to go. And we're going to figure this out. And that's the whole idea of coming together and how you connect with the real drivers of health and health care. So the example I'll give you is that when I came back from the Senate, I said, what can we do? And I said, let's get together as a community where health care is bad, or where health is bad. Health care is good, but health is bad. that has the resources, and we started a thing called Nashville Health. And I'll use it as an example, and it applies to rural communities, every town, every village. It's the same approach. It comes back to the community and bringing people together, making a diagnosis like I do in the heart transplant world, and then putting together a plan, and then integrating everybody together, not excluding anybody, taking all ideas, and then being held accountable for that. So in 2016, now just 3 years ago, we pulled together a group of committed people, not just the rich people, not just the community leaders, but the advocates, the activists, the potential patients, and people on the ground, and put together a collaborative, a collective, all ideas, nobody excluded. And that word collective and collaborative is something that we'll keep coming back to. We said that health services, the transplant world and the doctor world, only has 10% of the impact. 40% of the impact is in these social determinants. 30% is genetics, 20% is sort of socioeconomic, how rich you are, and your environment. But the 40% is what we're going to be talking about over the next couple of days. The whole concept of zip code being more important than your genetic code. It's the 40% versus the 30%, both very important, but the 40%, the determinants are something that we collectively can address. The genetic code you can't really address. And your genetic code in the rural areas is different than what it is in downtown Nashville or in North Nashville that is worse than the rural areas. But the importance of geography is important, not so much about where you live, but those determinants of housing, of transportation, of access to the internet, of the food you have access to, of the parks that you can walk through, or the urban design that has that impact, or the nature. Do you see trees? If you're in a hospital, if you see a tree out of the window of the intensive care unit, you will probably, in all likelihood, at least statistically, be discharged from that intensive care unit about a half a day sooner as you would if you didn't see that particular tree. Do we spend enough? Money is part of it, and money is something that does need to be addressed. And it's interesting, our outcomes in this country are not as good as other developed countries in terms of how long we live, or our quality of life, or infant mortality, but we spend twice as much. And then people say, well, you need Obamacare, you need Clinton care, you need Nixon care, whatever. But it's not really the way you think about it. We shouldn't think about it that way. We spend twice as much, and our outcomes are only half as good, but spending more will not move that needle. It has an impact, but it's not the answer. It depends on what you spend it on. For every dollar in this country of health care that's spent on health services, other countries that we're compared to, where we're not doing as well, spend $1.70 on social services that involve the social determinants, the housing, the food, the poverty. So every dollar on health services, they spend $1.70. How much do we in our country spend? Only about 50 cents. So it's part of the answer, but it depends on what you spend that money on. So Nashville Health is all about leveraging resources, collaboration, leveraging those resources to address these particular problems. What we did is we gathered partners. We brought diverse leaders in together. We sought to collectively determine the strategies. You can't do it all, so we focused on hypertension, high blood pressure, the #1 killer of people in Nashville. It's obesity. It's related to the metabolic syndromes of diabetes, but hypertension is #1. It comes very close to smoking. 22% of people smoke in Middle Tennessee. Again, a major driver. And the third bucket we chose was child health. Again, I told you our infant mortality here is higher than Charlotte or Cincinnati or Dallas or Fort Worth. Why is that? And then we chose the last that I just mentioned, this whole area of health and nature and our surroundings and our environment itself. There's several things we got to do. We got to leverage resources. We got to reach people where they are, #2. #3, we need to partner smartly. #4, we need to engage research. And with those, real quickly, how do you leverage resources? Just a couple of examples, not really stories, but sort of examples. In the area of hypertension, in terms of leveraging resources coming together, we partnered with the American Medical Association and the American Heart Association to put together, again, leveraging each other, a unique program on hypertension control called Target BP. In just 2 years' time, we were able to join more than 16 clinics and hospitals involved in a program that addresses hypertension in over 600,000 hypertensive patients. It didn't exist 2.5 years ago, but by collectively coming together. Number two, we need to reach people where they are. The same sort of thing, instead of people coming into a hospital, and there are fewer hospitals in the rural area, and having people to come see Bill Frist, the doctor, we need to have health and health care with no address. We need to go to communities and have the communities, especially in rural communities, own the issue. It's the dignity, it's where the need is identified. And it doesn't have to be just policy planners or people at the academic places. That's important, but it's really local ownership. So we collaborated with Cedars-Sinai, Vanderbilt, others to secure an NIH grant to bring unique hypertension treatment model to our community here, reach outside and bring resources here in order to address this diagnosis around blood pressure. Partnering smartly, what we've had to do, and again, these are all sort of principles that we'll be coming back to. We partnered with the Campaign for Tobacco-Free Kids and City Health in this Hold initiative and the De Beaumont Foundation and Kaiser Permanente to address the statewide tobacco use. Language is important. We'll come back. What you do is important. When you're talking to an individual, 22% of people smoke in Nashville, Tennessee. That doesn't mean very much. But when you say in a population of 700,000 people here in Middle Tennessee, 22%, that's 140,000 people. If you just had a program to take it down to the national average of 17%, that's about 40,000 people. You give each of them 6 years of life. So when you're trying to get support, you can basically look at a CEO and say, support our program here, because if you do so, and we just hit the national average, there are 240,000 years of life that you, the CEO, can help save. It's this kind of language that we use as we go forward. Number four, engage research. In child health in our city, too many infants die before their first year of life. And so what we did is conducted, and this was the help of Tivity Health, as you might expect, overall, because of what you heard Donato describe today of getting involved in a community, getting engaged in that community, participating, giving, in not a way that Eve is recognized, but they helped supported this basic research, first of a kind, in-depth research around infant safe sleep in Nashville. Again, Tivity and others participated as well. But this research informed us and launched a statewide sleep awareness campaign, and we partnered with faith-based communities. The environment I mentioned, and I won't go into the details on it, but it's worth thinking about when we talk about social determinants overall. It is food, it is housing, but it's also things like environment and access to the internet as we look at virtual health. Lastly, data is fundamental, and we need as much data as we can get. At Nashville Health, what we did is launched a Nashville Community Health and Wellbeing Survey. There hadn't been a comprehensive survey. We know about heart disease and how much heart care is delivered, but a comprehensive survey on the social determinants of healthcare and the behavior in this ecosystem of social determinants. And we did this first comprehensive survey this year to give a baseline so that when we do have any kind of intervention or program, that we can look from this baseline and see what the result is. If we have 22% of smoking, we go to 20% and 17%, we had an intervention, we can measure that. But to get that raw data is very, very important. This to policy, just because the majority, policy matters as well. When we talk about seniors and we talk about care, when I was majority leader, the first bill that I was able to pass and to write and to support was the Modernization Act of 2003. For the first time in the history of this country, prescription drugs were reimbursed, were provided by Medicare for seniors. Up until 2003, you could get supplemental plans, which a few, I guess, could afford. But right now, when you talk about prevention, you look at hypertension, you look at heart disease, and we don't need to go into the details, but the policy itself matters. Everybody has to be at the table. So with that, clearly I could go on and on and on, but who better, and come on up here, back up here, Joe, because for the next, I don't know how many minutes we have, but we got 30 minutes, but we're gonna, now that I've set sort of the big picture, come back and have some fun, and we haven't rehearsed at all. And I didn't get dressed appropriately, I can tell.
Yeah, this is called midlife crisis. That's what this
All right, so let's go.
So yeah.
Let's go in.
So let's have a seat if you
You
like.
want to sit? No, let's stand up.
Yeah, we'll stand for a little bit.
You can tell we hadn't rehearsed this.
Actually, I want to pick up on something that we touched on before, but you brought to life again, which is words matter. I mean, if we're going to use the storytelling theme to kind of make things hook, I'm going to take on something that my colleagues in academia are going to hate, and a lot of people in the medical world are going to hate: social determinants of health. Who are we talking to?
I've never used the words, except I did here to get it started, and then I'm not going to say it again.
Yeah.
Let's go ahead. What about it?
Well, this room could be so much bigger if we would speak English.
Yeah.
What do we mean by it?
What is a social determinant? And I think the language matters, and I mentioned it earlier. For communication, we need to use the right language. We don't use CMS and we don't use all this. I don't use social determinants in all seriousness. I basically say non-medical drivers of healthcare, or I'll say social drivers. But why don't you use social determinants? Why shouldn't we use it?
Because I do believe that language matters, and because if we want to get people to move in a direction, to stop smoking, to choose wisely where they live, how they get around, we should distill it down into what people understand. So for instance, in my field, originally transportation, we don't speak of transportation, we speak of mobility. Most people think mobility means a walker issue. Most people think it's driving. And yet transportation, we know, is a very important part of healthcare. Have you come across that when you were doing work in Medicare, Medicaid, how people get there?
You know, and again, the video, the storytelling, we captured it just an hour ago, both the imagery of it and the visuals and the words that we actually use. But if you have prevention as the goal, and you have to get a mammogram, or what Katie was talking about in terms of the whole issue of screening, colonoscopy and screening, how do you get there? The most important thing for breast disease, in my mind, is whether or not there is a parking lot close by that imaging center, because transportation is so important. If people can't get there, and they can't get there in an easy and affordable and accessible way, they don't get that mammogram. If you don't get the mammogram, that little lump becomes a malignant cancer, and it goes on and on. So transportation.
And even if you do get the mammogram and you need treatment, if you don't get back there for the treatment. Think about this: 70% of Americans over age 50 live in suburban or rural areas. If you don't drive, you don't get out. And by the way, the bus doesn't always come or exist. So I think, keep the rural, if you will, in the aging discussion. That needs to be part of health, I would think.
This transportation issue, we can move to wherever you want to go. Yeah. But we just had a huge...
Mixed metaphor intended, right?
Yeah, that's right. We can mobile wherever you want to go. We just had a huge debate. The public policy, we integrate all this, the public policy with health and healthcare and with innovation and creativity. That's the secret. That's the magic to do this. Had a huge debate here in Nashville, Tennessee. And I didn't want to get in the middle of the debate because I wasn't here enough. I've been moving around the country. But I wrote one article, and that one article said, let's look at transportation through the eyes of health, the nexus of health in transportation. And I'll have to say, all the things that I've tried to write a lot in the last few years, last 10 years, of all the things that I've written, people responded to that best, because all of a sudden you're taking transportation and you're talking about it in the language of health and to health care.
And it's consistently, and each White House Conference on Aging throughout the years has consistently been a top 5 issue. Health and Human Services has spent more on transit than actually the Federal Transit Administration did for many years. So if we can't get there, now we had this chat at MIT, the answer is technology. Now what's your question? Part of it is can we bring, I like the phrase you used before, which is, can we bring healthcare to where the people are? In part, technology might be the answer, but we also discussed kind of there's a problem with that, didn't we? Particularly in rural America?
It's easier conceptually to take what used to be in my head as a surgeon or as a doctor, and you take it into this world of non-medical drivers and get it to a phone or a device than it is to take a person an hour and a half in Appalachia or northern New York or a rural area and bring them to a facility an hour and a half or 2 hours away. And the neat thing about it is that we can do that today. Yep. So I don't even know if we should use the word technology, but the whole idea of Bill Frist, and I'm just going to use it because I'm a heart specialist, of being able to have further reach than people coming to Vanderbilt, 2 miles from here, where I could potentially have access to 500 people in the same amount of time using the telephone or the video. And it's the whole idea of virtual healthcare, that health really should have no address, and the technology is there.
But part of that context, particularly as we speak about a rural America, you mentioned we were chatting earlier, although I grew up outside of Philly, my family for many hundred years has been in far upstate New York. And most people do not equate New York with rural. But there are parts of upstate New York that do not have cell.
Where is New York?
Yeah, well,
you're a long way away from Nashville.
You have to understand, my family believes anything south of Syracuse is a confederacy.
Yeah.
So,
well, Virginia is north. Virginia is north, but that's here in Tennessee.
But think about it. There are a lot of us are waiting for 5G.
Yeah.
A lot of us are waiting for any G at all.
Yeah.
And so as a result, telemedicine, which has been around since the 50s, has gone nowhere fast. So I think part of our mission should be to improve that accessibility, not just to have access to it, but to have the technology be there.
And the infrastructure is where we're going.
Yes.
This is pretty good for never having rehearsed this.
Yeah, we're going to go on the road next week.
But anyway, but the infrastructure itself, again, public policy is important. So when I go through social determinants itself, I threw in the top 3 internet access. And why is it? Because not the only solution, but to be able to take the reach and the access both for the prevention side as well as the treatment side to where what's in my head or as a physician could be anywhere in the world of virtual healthcare. And we did talk really just 15, 20 minutes ago that I am in Southwest Virginia, Craig County. Where are my Craig County people here? All right, 3 people in the back. And Craig County is probably in the bottom quarter of counties in terms of wealth, probably lower than that. It's in Appalachia, beautiful place, unbelievable people there, but right there's no access to sort of health and healthcare. The problem is where our house is, up on 42, and sort of doesn't matter exactly where it is, until about a year ago, we still don't have internet, sort of fiber optic, and we didn't have cell phone coverage at all. And so if you don't have any cell phone coverage today, and you don't have fiber optic in terms of video coverage of getting Bill Frist, the heart specialist, into the home, which I can do, technically it's there, but unless we have that infrastructure there. Does New York have rural areas?
We have very rural areas. In fact, Oswego County for many years was actually ranking higher on a list you don't want to be higher on in terms of health, alcoholism, and all kinds of issues of abuse than many parts of the country that you would expect. And so as a result, they find there's great isolation there. So, as we talk about accessibility and infrastructure, you should know the technology is there and has been there. The infrastructure to deliver it is what we're identifying now, whether it's 5G or broadband. But there's one other part of infrastructure we were discussing. I know this is close to your heart. What is disappearing in rural America? Hospitals. Community hospitals. So this notion that telemedicine, a checkup a day in your kitchen, is a great story. But if you want to do rehabilitation, which is part of telemedicine, teletherapy and the like, you're going to have to go to some place. So for all of you that are taking notes out there as storytellers, ask yourself, if the community hospitals go away, do you have platforms to be able to bring this technology, assuming you have connectivity, to provide the places for these services to be provided? And right now, they're not there.
They're not there, but we have to think creatively. Again, I'll refer back to Craig County. But Craig County is an area, again, it's far from, not that far, but it's far from Blacksburg, it's far from Roanoke, the nearest centers themselves. Why not take a library, so similar to the Starbucks concept, and have the library, the centeredness, the center node, It hits the loneliness that Katie and Donato talked about. It puts the engagement there. It allows you to take a hard line there and deliver that sort of engagement in a privacy-protected environment. So we have to think creatively about these environments. In Tennessee, 17 rural hospitals, and maybe more than that, have closed in the last year and a half. Where do people go? Just on the virtual healthcare, because I don't know where we're going next. There are 1.4 billion visits between healthcare providers and individuals a year that are in-person visits. I am on the board and help sort of move along and take public a company called Teladoc. We are by far the largest telemedicine company in the United States of America, by far. 80% of the market of a consumer talking to a doctor. It's pretty neat because you can do it within 8 minutes. So right now, if I wanted to talk to a doctor, or you that are visiting from out of state, and you don't know where to go, if you have the worst sinusitis or the worst headache you've ever had, or a big sty that's getting worse, within 8 minutes, you go to your phone, you push it, within 8 minutes, you'll have a board-certified doctor in Tennessee there who can write prescriptions. And that's what you can do. What's interesting, we're by far the biggest. I said there are 1.4 billion physician, nurse, patient interactions. We will do 4 million visits, and all visits is only 10 million. And it could be 400 million visits. So we haven't even touched the surface. But where's the real magic, the real sort of benefit going to be? It's going to be in the rural communities, I think.
And I think we need to think creatively about the sense of place. So we see the explosion of retail clinics. Where are the retailers in this room, or should be in this room, if you will, providing that outlet of health care and connectivity? I have a cousin who is receiving Parkinson's care. And she, if you go back to my upstate New York, my family's from the Canadian border, so it's basically the welcome to Canada part. If you make a right and go to nowhere, that's where they are. But she's getting Parkinson's rehab from Johns Hopkins because one of the local senior housing communities is offering therapy on site. So can we start thinking about institutions, whether it's library or the like, that we can do that?
Where do you get those red shoes?
So my 16-year-old daughter is horrified. You know, that's right.
No, that's looking pretty good.
Yeah, yeah, there you go. We got. Where's Waldo?
Yeah. Okay.
So here, I'll tell you where we're going to go next.
Tell me.
We're talking about institutions and whatnot. Something that really broke my heart, even though and Katie mentioned it and Donato mentioned it. We know the numbers.
Broke your heart. I can fix it.
Yeah. There you go.
But I got to cut it out first.
Yeah, and replace it hopefully.
Yeah.
But here's something that we know the numbers, but it hit me harder. As a student of institutions, it hit me harder when I saw it. This is in Massachusetts. I went to the town next to where I live, the former home of Digital Computer, Maynard, Massachusetts. Beautiful Methodist church has been there for many years. Flowers are still there. The plants are doing great. You know what the sign said in front of the Methodist church? Church closed. Do you know the Methodist church is losing one church per month? Catholics have lost 2 million, temples are closing. And I'm not making a pitch on faith-based, but particularly in rural America, it was the faith-based institutions, the VFWs and the like, that gave us the social capital, another jargony term for connection with people that you like, that provided care. Do you see that being
well, again, you're in New York. In Tennessee, where we are now, the faith-based community is the leader, obviously in engagement, spirituality, but also in
connection,
cutting edge of connection, and the loneliness and the health. And it is, and I didn't go into all the notes, but in Nashville Health, where our whole job is engagement and collective and collaboration, but then also execution and action and measurable results, which we can do today, which we didn't used to be able to do, but you can do today. It really starts in many cases with faith-based initiative. You know, we also have a lot to learn from other countries who are more rural. I'm talking about countries where I've gone for 25 years. I spent 2 to 3 weeks a year in Sudan and Ethiopia and Kenya doing just general medicine and surgery. And I learned a lot there, and it's the community health approach. It is the sort of, and these are not doctors, there aren't no doctors there, but the coming together of communities and engaging communities. And once again, if you go to Sudan and you go to Kenya, and you go to Ethiopia, and you go to Rwanda, you'll see the faith-based community are the most innovative, the most engaging when it comes to health. And that's really where I worked. And again, in the South, it's very popular, and I guess in New York, people go to church.
Unfortunately, if you look at the data, the South is strong in the older population.
Yeah.
Around the country, we are becoming more like Europe every day. So the secular society is loosening that glue. And so if that institution is no longer there, where are the VFWs? Or when I was growing up, the Agways,
Yeah.
the places where the old guys had a cup of coffee and stayed connected.
Or the kitchens, and again, I'm thinking of Craig County, or people who are knitting together with 12 people. The kitchens and the shared sort of presentation of food and farm to table. What about social media? So obviously, and this is really complex, and I know we don't have much time, but people hopefully will talk about it the next few days. Yeah. Social media is the headlines. It is bad. Yeah. It is privacy stolen from you. It is manipulation of our government itself. All of the bad things that we hear about. But isn't there something to the connectivity of having 30 friends? Again, in not just rural areas, but everywhere. And it may be on Facebook, it may, which is the sort of evil one out there right now. But doesn't social media have a huge positive potential for the loneliness and engagement?
And this is, I'm looking at, I have a colleague here from the Age Lab, Adam Feltz, who's sitting over there in the cheap seats. But we're looking at, I'm curious as to whether it does. I can't give you a straight answer. Think about this. All the studies have been out there saying that social media has caused amazing depression amongst the young people because they have FOMO, fear of missing out. Here's a hypothesis. I have no idea. I'd love to chat with you guys during break. Will older adults who are watching on new social media channels that we connect them into, will they be more connected or will they be more depressed? Because if the 16 and 20-somethings feel that they're missing out and they have the ability to get out and connect perhaps, how about those who can't get out? I don't know.
I agree.
I think, look, technology, as I told you earlier, is the story of the future that is positive, but it's also wrought with challenge.
But if you're the 78-year-old sitting in a small farmhouse, still doing your own molasses and cane sugar, and you're a community to be able to every morning get up and talk to your relatives across the country, to be able to talk to your friends who are 8 miles away. We have it to work out, but I think you can sort of play it anyway, but we can't turn it off. There's a lot that we need to learn coming forward in the whole social media.
I want to save time for a question or two from the group here, but one of the things you may find counterintuitive if you're a sociology type geek, do you know that the literature over the last 5 or 10 years was showing that even people who live in urban areas, in apartments, right next door to their neighbor, were showing higher levels of depression than those who are 400 acres apart. It's how we keep those connections. And I think that virtual is, high tech is better than nothing, but I don't think it's going to replace high touch. On the other hand, just because there's proximity does not mean that there's connection.
And it's not technology and high touch. Yeah. I mean, I grew up here. My dad was a physician here, so I grew up in the era and still believe in today that you need to see a patient, you need to touch them, you need to take the breath, you need to sit down, you need to be at eye level, you need to just, in 6 minutes, we're connected. Yep. The interesting thing is that technology can do that today. With Teledoc, when I first started that, I couldn't really, I said, it's going to work, but not really work. But today, again, it's more young people than others that I thought they'd want to see the video, on the iPhone. And they did, but then they said, we don't need to do the video, just give us the telephone. And then they said, we don't really need the telephone, let's just do text. Right. And so we have to be adaptive, and we can't force our culture on, and that's why we start with those local communities. A quick example, I know we need to go. There's huge disruption, so this is painful, but the disruption gives you a huge sense of optimism.
Yes.
Disruption, there's a company that you'll hear more about that I'm involved with called Smile Direct. Right now, and the equity issues, again, we need to talk about, but Smile Direct basically is braces. It's basically straightening your teeth. Right now, orthodontists to have braces, and most people who have braces, cost about $6,000. Vulnerable people can't afford $6,000. And with crooked teeth, especially with Facebook, where everybody sort of judges people on appearance, in terms of their education, their dignity, you're judged, is outside the scope of the average person today. It's $6,000. So Invisalign came through and did a pretty good job with these little trays that you put in, but why not go directly to consumer? You go directly to consumer for $73 a month. This is kind of an advertisement, but not an advertisement. All of a sudden, vulnerable people, and $73 is a lot a month, but it's not $6,000. I tell that story, and that company's a small company, just moved to Nashville 2 years ago, but that company has the potential impact of changing the world. But it's very disruptive because you have orthodontists who, and again, I'm a cardiac surgeon, this is what I kind of used to do, who get paid $6,000 for doing something that, for the first time ever, vulnerable and sort of mid-economically driven people have access to give them this sort of dignity and all. It's hugely disruptive, which is the point, because all of a sudden dental care and the orthodontist, they're going to say, why? Is that right? So a lot of what we talk about, if you think outside the box, you have to recognize that disruption has its really positive impact, that millions of people have access to care in rural communities who didn't have it in the past, but at the same time, it's hugely disruptive to the medical professions. And it's just the way it is. Telemedicine, the same sort of thing.
So we're going to take a question or two, but I want you to think of what we addressed. We talked about transportation. You know, before you do anything, you got to get there first, whether it's healthcare, connectivity, whatever it is. And by the way, the transportation that is the most important to older adults, believe it or not, it's not going to the doctor. For all of us who said, don't worry, Dad, I'll get you to the doctor, that's not what he was interested in. And it was not going to the grocery store. You know what it was? Seeing a friend. So we talked about transportation. We talked about technology, equity, being able to afford technology, social capital, which is basically what we used to call friends before we got geeky. But there's something the Senator just touched on. I want to make sure that we don't leave for the rest of the conference and come back to it. The word optimism. Having an optimistic belief that you have the courage and the capability to make something better takes courage. Pessimism, that it's all going to hell in a handbag, is either a great excuse to do nothing or, frankly, the admit that you're powerless. We want you in this room to go forward and have that optimism that there's a way, there's a pill, there's a product, there's a purpose, there's a technology that can make things better. Optimism is a key part of any story worth following. So on that note, we've got time for one or two questions. Who's it? Katie. Oh. We've seen you before.
I know, but hi, Senator.
Hello, Katie.
How are you?
How
nice
are
to
you?
see you. So you all addressed a lot of things that are changing in rural communities, but the one thing you didn't talk about were, at least I didn't hear it, demographics. You know, I did a Nat Geo special on sort of rural America, and I profiled a place in Storm Lake, Iowa, that's a minority-majority population in the middle of sort of the red state of Iowa. And I'm just curious how that's affecting the support system. I'm sure many of the people here know about this. The support system's in place because as young people leave rural communities, elderly people are dying out. Right. What does that portend for all the issues that you're addressing today?
You want to start?
I'll just give you one point of color. My friends from Maine, raise your hands here. Maine is one of the states that actually is giving in-state tuition to out-of-state and international students because, frankly, they have no young folks. Iowa, basically the same problem. So yeah, that demographic shift is having a major impact on who provides care and how we remain connected. Senator?
And I will say, again, we're just sort of the warm-up. Like Kara, who is in charge of diversity and minority issues for Health and Human Services, is an expert, and she'll be addressing that very specifically. But the language is the start. The local ownership is the start. Access and transportation, the geography. If we stay flexible, we stay fluid, we have to have the appropriate resources. The demographics, they're changing radically. As these 17 hospitals close, healthcare, people are coming here for healthcare, and then they're actually moving here.
And it's about workforce, too. They leave, yeah.
Exactly. So those are exactly the issues that we'll be talking about over the next several days. The one issue we didn't talk about was food, which is a huge one we'll also be talking about. There's somebody in the very, very back. Go ahead and say who you are real quick.
Senator Frist, can you hear me okay?
Yes, sir.
Keith Branson, I'm director of Westminster Home Connection. We're a small faith-based nonprofit that grew here in Nashville 6 years ago after the flood. We do affordable repairs and mobility modifications for low-income older adults. So we represent the faith-based and the communities coming together, the volunteers, the neighbor helping neighbor. But I think the reason I'm raising a question now for you is about language, because you didn't talk about housing, which is on the list. And I believe housing gets lost in thinking about places to go to live or rental assistance, when in the urban area, as you know, we have an affordable housing crisis here that doesn't make the headlines of the city. And retention of the property for the homeowners to age in place is a battle of language that I personally have with what we do. But when we go to the rural areas, it's still a uniform problem of deferred maintenance, getting repairs that are affordable. You get medical help and rehab, but when you come home, you can't get in and out of your home. There's no way for grab bars or ramps and so forth. So I guess the question is how we make the retention of homes and affordable repairs more prominent in the conversation in the language and definition of housing needs for people, especially maybe at a policy level where there can be funding geared toward that.
Yeah, it's a great question. It applies broadly and real quickly. And again, we'll address it over the next 2 days. But the silos that we have traditionally in the field of non-medical drivers, where transportation, how does that relate to housing? How does that relate to internet access? This integration, this collectiveness, this collaboration is what it is. So I opened with Nashville Health, which is a model. It wasn't because Nashville, but it said, I hope that each of you in your communities, and it could be in Sinking Creek, Virginia, where we are, or it could be in Cincinnati, brings people together and puts 7 or 10 or 12 or 30 in the same room on a continuing basis. There are 120 nonprofits doing health here in Nashville, again, within 5 miles of where we are right now. Until we established Nashville Health as the convening entity, they had not been together. The people who are focused on housing had not been with transportation, had not been with the food people. And once you put them together, all sorts of magical things start occurring. And you have to align. We took 4 buckets, which I explained. And you take 4 buckets, you say, how are we going to address that? Then you have 120 nonprofits, you have 115 business communities, you have the political leaders all using the same language. And the language affects the policy, and the policy feeds where the resources come from, and then you can start applying to foundations around the country. But again, we apologize. Obviously, we're unrehearsed, obviously, and so we didn't touch on all the issues, but housing, you'd put right up there at the top coming in.
One more question, I think we're good to go. Sir.
Yeah, I'm Byron Camp from AARP. You've touched on many, many issues. I had the privilege of attending a session at the YWCA here in Nashville recently, and it was titled Humanity and Health. I'm reading a book that's written by, the title is Well. It's written by a physician who is head of the Boston Health Services, or for the city. And what they're talking about is kind of like where you are is where you were when. So it's the social issues that are so important in talking about obesity in Tennessee, talking about smoking in Tennessee, talking about hypertension in Tennessee. What you said is really important, the difference between health and health care. And this is what, if we're going to talk about health, how are we going to work to change people so that they can change their lifestyle? But there's so much that goes into that. Are the nonprofits and those other organizations be the one who are going to go out to the areas, to the communities, and change and help teach and help them learn and have the resources to do this? Or are we looking at public policy?
I'll come right back.
This has to happen if we're going to make change.
No, great point. You've got 3 big spheres. And one is public policy. and it'll come back. And I'll give you an example. The second is health and healthcare and medicine and science. And the third is this whole field of disruption. And it's the nexus of those three dimensions that the great transformative change will occur. The transformative change, and we talked about so many issues, but the central organizing force and energy comes with three words, and it's culture of health. We all need to use the same language to establish a culture of health in our communities that values prevention, and it takes with basic knowledge. And again, if you have 120 nonprofits kind of doing this here, unless they are organized, because each one has their own little board, their own initiatives, very good, very effective. But if you put them together around a common goal, all of a sudden these synergies come alive. And they have to pool their resources. They don't have to give them away. But that's where the organization, and the same question on the housing coming in, that communities have to come together and take advantage of the great strength and energy and dynamism in the nonprofit sector and work it with the for-profit sector. And that's, at least that's what I conclude as we move forward.
Yeah, it can't be, is it government or is it business or nonprofit? The answer is yes, depending on who that population is, all the above.
But policy, I know we're out of town, but policy, that was the last question. Wrap up, please. That's what that said.
Yeah, with a smiley face, I might add. Thank you.
I gotta go buy my red shoes. But but policy is like Medicare, for the first time in 2020, is gonna reimburse, for the first time ever, reimburse telemedicine. It took Medicare. Right now, this year, go into next year, for the first time, Medicaid and to a certain extent Medicare Advantage can reimburse for food. Using food as a prescription, using food to be able to change. You can write a prescription, you can be reimbursed. There are companies like Mom's Meals that does like Meals on Wheels. So all of a sudden our federal government for traditional health care programs like Medicare and Medicaid are paying attention also to housing, but to food and to telemedicine for the first time. It comes from that change in culture. We gotta get out of here.
Thank you for your leadership,
Thank you all
sir.
very much. Appreciate it.